In this presentation, we'll be looking into relining and rebasing in complete dentures. Relining is a procedure used to resurface the tissue site of a removable dental prosthesis with a new base material, thus producing an accurate adaptation to the denture foundation area. Rebasing is a laboratory process of replacing the entire denture base material on an existing prosthesis. Introduction. Materials used in complete denture prosthodontics are vulnerable to certain changes because the denture may discolor or deteriorate and the artificial teeth can fracture or become abraded. Meticulous attention and care in the construction of complete dentures will minimize adverse changes in the supporting tissues and associated facial structures as well. The clinical efforts that aim at prolonging the useful life of complete dentures involve in refitting of the impression surface of the denture by means of a reline or a rebase procedure. Resorption pattern. Resorption occurs more rapidly in the first 6 months immediately after extraction of a tooth. The rate of resorption progresses after 65 years of age. It is more rapid in females than in males and can be precipitated by certain systemic diseases or by ill-fitting dentures. The observed clinical changes in case of an ill-fitting denture include loss of retention and stability, loss of vertical dimension of occlusion, loss of support of facial tissues, horizontal shift of dentures leading to incorrect occlusal relationship, reorientation of the occlusal plane. Treatment rationale. The resultant spatial reorientation of the dentures on their supporting tissues and occlusal surface leads to changes in circumoral support and consequently in the patient's appearance. The changes in occlusal relationships also induce more adverse stresses on the supporting tissues, which weightens the risk of further ridge resorption. This questionnaire guides us as to what is the right treatment to undertake. So, if the mandibular position and the occlusal relationship are correct, and if we see there is inadequate strength or discoloration of the base, then we go for rebasing. But if there is no discoloration and the base is strong enough, and if the base is thick, then relining is enough. But if the mandibular relationship and the occlusal relationship are incorrect and there's no improvement even after adjustment, then this leads to new denture fabrication itself. We cannot go with relining or rebasing procedures. Indications for relining and rebasing include residual ridge resorption, immediate denture, when patient cannot afford new dentures, geriatric or chronically ill patients, a new denture which doesn't have the expected fit at the time of delivery. Contraindications include excessive amount of resorption when abused soft tissues are present, TMJ problems when the denture base itself is in poor condition or of poor quality, poor teeth arrangements leading to poor aesthetics, unsatisfactory jaw relationships, and severe bony undercuts. Tissue preparation. Excessive hypertrophic tissue should be surgically removed. The oral mucosa must be free of irritations. Removal of the dentures from the mouth during sleep is a must for several weeks before treatment commences. The denture should be left out of the mouth at least 2 to 3 days before making the final impression. Daily massage of the soft tissues is helpful to stimulate their blood supply. Denture preparation. Pressure areas in the soft tissue area of the dentures should be relieved. Minor occlusal disharmony is corrected by selective grinding. Small border inadequacies are corrected. A correct posterior palatal seal area should be established before the final impression. These are some features which we should look out to and which must be present to prevent pitfalls after relining and rebasing procedure. Relining procedures. The clinical procedures include static methods such as open mouth technique and closed mouth technique, functional methods, and chair side technique. Laboratory procedures of both relining and rebasing include articular method, jig method, and the flask method. This is how we decide the material with which we will reline or rebase. In case of loss of fit, function, comfort, or health after complete denture insertion, we should first check the tissue status. If there is healthy tissue, then we can use hard acrylic solution. If there is mild to moderate tissue damage or surgical intervention is required upon short-term or long-term basis. In case of incremental layering required to achieve ideal contours, we will use resilient acrylic. In case ideal contours can be achieved in just one application, then we will go with silicone. In case of severe tissue damage or surgical intervention, very short recall, tissue conditioner is used. Boucher's technique of relining. This is a direct relining procedure used to improve the fit of existing denture. In relining clinical procedures in static closed mouth technique, we have technique A, B, C and D. In technique A, centric relation is first recorded. Under denture preparation, all the undercuts are relieved except in the posterior border. The palatal portion of the maxillary denture is removed. Border molding is then done and reformed to their functional contours. The advantages of this technique include the opening of the palatal portion helps to alleviate the increase in vertical dimension, and also the pre-made interocclusal record helps to position the dentures during the impression making and to orient the dentures on the articulator. Disadvantages include the possibility of the moving of maxillary denture forward, no solution for difficulties of relining both dentures at the same time. In technique B, the existing centric occlusion and intercuspation are used as a means to seat the denture, and similar as the previous technique, undercuts are relieved under denture preparation. The palatal portion is deepened on the polished surface up to half the thickness of the denture base. Holes are drilled at 5 to 6 mm intervals inside the groove. This helps in the easy removal of palatal portion during packing and processing. Iowa wax is the material of choice. The impression is made in 2 steps. The impression of the labial flange is made first. The crest of the alveolar ridge between the canines is made as a second step. Technique C is a combination of both the A and B technique, and it combines the advantages and disadvantages of both. In technique D, a large opening should be made in the palatal portion of the maxillary denture. Adhesive tapes were attached over the buccal and labial surfaces. A fairly deep groove should be cut into the buccal and labial surfaces of the dentures. This is done at the junction of the impression material and is filled with base plate wax. Coming to relining clinical procedures, functional methods. First, we'll look into Winkler's method. Patient need not be without dentures. Tissue conditioners are used as impression material because of ease of use, good dimensional stability, good bonding to resin denture base, and excellent refitting of the complete denture. A minimum thickness of tissue conditioning material is placed over the tissue surface of the denture and evenly distributed. The denture is then inserted into the mouth with proper anterior-posterior relationship. The patient is instructed to tap the teeth together lightly to position the denture and to hold the teeth together lightly for 3 minutes. Then the patient is engaged in conversation or to read out loudly for an additional 5 minutes.